Hello everyone, I'm Andrei Voiosu, and it is my pleasure to briefly present this video of our perspectives piece entitled Before You Implement a New Technique or Technology in Your Unit, a Strategic Perspective of Endoscopy for Gastrointestinal Endoscopy, on behalf of myself and my co-author, Professor Mario Diniz Ribeiro. The paper I shall discuss has organically developed from my fortunate meeting with Professor Ribeiro during an endoscopy fellowship supported by the ESG. First, some background to the story. I work as an endoscopist at Colentina Clinical Hospital in Bucharest, Romania, seen here. Bucharest is a city of roughly 2.4 million people, the largest in my country. Because I have been fascinated by the technique and possibilities offered by ESD since encountering it at a live demo years ago, and at least to my knowledge, there is a single high-volume center offering ESD on a regular basis in my country, and that in another city, I strongly believe there is an unmet need for endoscopists trained in this advanced intervention in my home unit. Consequently, I had the good fortune of being awarded a fellowship to study ESD at the Portuguese Institute of Oncology of Porto in Portugal, under the supervision of Professor Ribeiro, a well-known expert in the field. To stretch this cross-cultural and international narrative even further, I must confess a strong admiration for all aspects of Japanese culture. So the acquirement of an endoscopic technique, which originated in Japan, is even more satisfying on a personal level. ESD is now well established, being performed in numerous centers of excellence across the globe, and has impressive results in treating and preventing advanced conditions and helping innumerable patients. But it also requires high technical and cognitive skills, presupposes some non-negligible risks, and involves expensive equipment and adequate settings. Born out of the very concrete question of how to implement a technique such as ESD in an endoscopy unit, a larger issue captured our attention. Why should one do it? There is extensive literature expanding on the East-West divide on performance and several excellent papers in how to introduce ESD in a Western setting, focusing on the difference in training, pathology and epidemiology, reimbursement, etc. However, there is less talk on the ifs and whys of adopting a new technique in a particular unit. Following this thread, we realize that these questions are applicable to any new technique or technology. The why must essentially come before the how. And it goes beyond medicine and endoscopy. The life cycle of technology diffusion states that the limiting step in uptake is the lack of information available about the technology. This may be one of the reasons leading to Rogers' differentiation between the 5 groups of adopters of a new technology: the innovators themselves, early adopters, the early majority, the late majority, and the laggards. But while this model describes the cumulative adoption of technology over time, it offers no guidance to prospective stakeholders and is not useful in a pragmatic decision-making setting. We set out to develop a model addressing this, and first explored what we called assumptions for implementing a new endoscopic technique or technology in a service. For an acquired skill to represent more than just personal achievement, it must be put to use effectively. It seems logical that a physician who is properly trained or credentialed in a technique needs to practice in such a manner that their implementation of the technique reaps the most benefit for all involved. For that to happen, some basic assumptions must be met. Firstly, when contemplating the implementation of a new, costly, potentially risky technique, the endoscopist needs to consider epidemiology and competition. Is the disease that requires the technique frequent in the population served by that unit? Is there anyone else offering the technique? Or is there an unmet need? We encourage discussions with colleagues with experience in the field, exploring available surveys on current practice in that particular area, and establishing referral networks early on. Secondly, making sure that the technique you want to implement is standardized increases local acceptance because it presupposes a mature technique and helps manage initial expectations. Performing a maneuver just for its sake is not desirable, obviously, especially in healthcare. So our third assumption is that the new technique or technology brings improved success rate or outcome, reduced procedural time or difficulty, lower morbidity or mortality, significant cost savings, or increased patient satisfaction for it to be worthwhile. The endoscopist must also judge if the local conditions are amenable in order for their project to be feasible and avoid frustration and failure. Endoscopy is teamwork, and no single practitioner, no matter how well trained and dedicated, can make it without proper training, collaboration, and oversight. Furthermore, we must not lose sight of the fact that the patient is always at the center of these endeavors and not the technique. Caring for a patient means more than performing a procedure, so everything must be in place in order for that to happen. Engaging the patient in decision-making when considering novel endoscopic techniques is paramount, has been shown to increase patient satisfaction. And our final, but definitely not our last assumption, goes without saying, since there are so many different hurdles. Motivation and strong personal determination of the endoscopist is key to success. Now, other variations of these key assumptions may come to mind, but bottom line is that there is a concordance between locally perceived need and feasibility, and this must be ensured for implementation to be successful. Let's look at 4 different scenarios applicable in all situations and what strategy seems logical in each instance. In our first scenario, there are few candidates that would benefit from the technique or technology, and we have very limited resources available at the unit. We may have many patients that could be treated, but very limited resources, which is unfortunately the case in many units all over the globe. You might have prospective patients that are quite few, but sufficient resources for your endeavor. And finally, and logically, the last scenario, the best one, where you have potential patients in sufficient number for a high volume center to develop and sufficient resources available. In each case, our model advises for a certain course of action, from abstaining or postponing to using alternatives to confidently implementing the technique as soon as possible. We hope that the simple model for decision-making that you can read about in this issue of gastrointestinal endoscopy can help you and other stakeholders when considering the implementation of a new technique or technology in their units. The road is not always smooth. Not every aspect of the decision-making process can be properly rendered or codified. Our model, however, is predicated on strong initial motivation on behalf of the endoscopist. And it will always hold true that if it doesn't come bursting out of you in spite of everything, don't do it. Thank you for your attention.